Good afternoon. I'm Angela Koppel. I'm the EMAC Program Director at the National Emergency Management Association. I welcome and thank you for joining us today for this webinar on the use of the EMAC system by public health and medical professionals, a discussion. This is the second of two webinars that we developed on EMAC for public health and medical responders. If you've missed our first webinar, you can watch a recording of it on the EMAC website at emacweb.org. As a follow-up to the webinar, we'll provide a PDF version of the slides on the EMAC website, as well as a recording of the webinar presented today. Again, the EMAC website is emacweb.org. Leon Shaifer, the EMAC Senior Advisor, is our facilitator today. Leon, I'm going to hand the webinar over to you. Thank you.
We're delighted today to introduce our speakers, our presenters for the second phase of this informative session on public health and medical use of the EMAC system. We're joined today by Ms. Mary Duley, Kathy Robinson, and Martha Salyers, all practitioners who I think most of you all are familiar with their names, certainly within the profession. And first of all, let me introduce our first presenter, who will be Mary Duley. Mary is the Hospital Preparedness Program Coordinator for the Connecticut Department of Public Health, as well as the State ESAR-VHP Coordinator and the State Medical Reserve Corps Coordinator. Mary has 25 years experience in emergency nursing, has been actively involved in the emergency preparedness and planning since the 1980s. In addition to serving as co-chair of the Public Health and Medical Working Group, the National Mutual Aid and Resource Management Project, Mary is a participating member of DHHS's ESAR-VHP Project Advisory Group and the Hospital Preparedness Program Executive Steering Committee. Mary has also written and published many articles related to the healthcare system preparedness planning for disasters. She's also a registered nurse and has a Master's of Arts degree from the University of California in Santa Barbara. Welcome, Mary. Mary will provide an overview of the EMAC Resource Typing and Credentialing Project and has responsibilities of the Public Health and Medical Working Group. The importance of pre-event intrastate and interstate mutual aid planning and how to request and provide assistance through the EMAC system. Okay, Mary, go ahead with your presentation, please.
Thank you, Leon, and welcome everyone to our presentation this afternoon. Like Leon said, I would like to go over with everyone some of the work that the Public Health and Medical Working Group has been doing with FEMA for the last 5-6 years as far as resource typing and credentialing public health and medical personnel, and then talk a little bit about mutual aid planning, requesting and providing assistance using EMAC. Basically, many of you are familiar with this initiative. We basically support NIMS. We're just one of many ESFs that are developing resource management documents and credentialing personnel that can be used for state-to-state mutual aid. We're all working with the same template and trying to move things forward and streamline things so when states are looking for assistance, they have the necessary tools to use. The Public Health and Medical Working Group was basically developed and brought together after Hurricane Katrina. As a result of the after actions in 2006, a group of public health and medical experts were asked to get together at the direction of HHS to look at some of what the typical public health and medical missions were during Katrina, and then see if we could identify and develop those teams so the states could use them not only for intrastate response but also interstate response. We had members from many states throughout the country. We had a very diverse group, and what we did was we looked to identify teams that currently existed or teams that could be easily packaged or put together by institutions such as hospitals or agencies such as local and state public health departments. What we wanted to do was to develop something that was capable of being ordered through a standard system. And this fit perfectly into the interstate mutual aid system of EMAC. And so that's what we used as a template to start to move forward. We wanted to develop these inventories and catalog these response assets so public health and medical professionals would have them as a tool. This slide just gives you an idea of the timeline of how we all got together. Again, like I said, many of us met around the holidays of around 2005 after Katrina to talk about the things that we felt went well and didn't go well with medical and public health response teams, and then started looking at what we were going to do. We decided on what those appropriate resource types were, and then we moved forward. The resource typing phase was done initially. We identified the teams and then went through stakeholder review and didn't start credentialing until the teams were actually approved. And then we moved forward through the steps. And as you can see there, we're still very actively working on things as we move forward. This slide only goes through 2009 when we originally had the original teams and the credentials sent out with the NIMS alert, but we are still working and very active, our group. We're currently working on fatality management teams and units, and which we're then going to credential, and we're also working on some mission support type teams for our public health and medical teams. So what we came up with after 2 years of very solid work and review and input from our stakeholders were 5 medical teams with additional sub-teams resource typed under that. We have the main teams were mobile field medical teams, emergency care and critical care team with sub-teams under that, ancillary support teams, specialty care, and palliative care hospice care team. And then each of these subsequent teams had sub-teams listed underneath them. For public health, we came up with 5 teams: epidemiology for surveillance and investigation, isolation and quarantine, environmental health, mass dispensing consultant, and an RSS task force team. We also found that combined teams were needed, and specifically as a result of what happened in Katrina, we saw there was a great need for a public health and medical combined team to go into shelters if requested, to not only evaluate the living conditions and the safety, public health and safety of the individuals there, but also what if some individuals were there that required medical attention. They needed public health and medical experts to be there to staff it, to make sure that nobody slipped through the cracks for medical care, and the public health assured that the food they were eating, the water, and the facilities that they were using were adequate. And then we developed a public health and medical health assessment team. I've always called this, for those of you specifically in emergency management, it's kind of like a public health and medical A team. They're like the experts in their particular state in public health and medical, and they could be called into a state or jurisdiction whose public health and medical system has been totally decimated, and they need assistance, and these people can come in at the request of the state EMA to go in and help the public health and medical people on the ground do an assessment of what's going on, what may be needed, and maybe assist them in requesting the teams they may need. After we got all these teams basically approved by our peers and the stakeholder group, we then credentialed 44 job titles. They were both licensed and unlicensed medical and public health professionals, from A to S basically, A being an advanced practice registered nurse, all the way down to our 44th job title, which is a surgical technician. And what we did was, in this process, we identified and documented the knowledge, skills, and abilities of the people that were going to be part of these teams. And that's why it's very important to identify the team first and then make sure that you credential a position to go along with the individuals on that team. Basically, as you know, under EMAC, the providers of the resource are really responsible for providing the requesting jurisdiction qualified personnel that have all the knowledge, skills, and abilities to perform the job functions in the mission. And so what we very carefully did was developed a description for each position and recommended and required criteria. and then basically added some different things that may be needed. We talked about the minimum level of education, minimum level of training, experience, licensing that may be needed for that individual to go on a mission. And for all of you that may not have seen them already, they all are up on the FEMA website under Public Health and Medical Working Group for both resource typing and credentialing, and they've been up there since 2009, so I welcome you all to visit that site, and you'll see that we have those all up for those positions. Mutual aid planning, I think, is what we're really here to talk about, because what we really need to do is decide now how we can best utilize these tools and these catalogs that have been developed to basically get the people that are needed to where they need to be. So we want to establish strong working relationships with our state administrative agencies that are usually our emergency management agencies, and work with those coordinators and authorized representatives to make sure that we have a good understanding of how the system works, how we can request assistance for public health and medical personnel, and how vice versa we could provide assistance to states if they're needed. And there's many things that need to be in place in order for this to effectively take place. But all of us now, all 50 states and many of the territories, are EMAC jurisdictions, and we do have the legal processes and the statutes in place to deploy resources. Some states still have not worked out the, quote, agents of the state process. I know Connecticut and Maine and New England have worked that process out quite well, where our public health and medical volunteers, even from the hospitals and private sector, can become activated in agents of the state. But these are things you need to work on in planning with your state emergency management agency. Interstate agreements and team compositions are very important, organizing the resources under state sponsorship. I've always said, and I think many of us have, you know, before we can help others out, we need to be able to have a system in place to help ourselves. So utilizing these tools for intrastate planning is extremely important, and once we have those agreements and those plans in place, we can benefit other states with the tools that we have. All of these resources are based on NIM standards. We're going to talk a little bit shortly about mission-ready packages, which are actually tools through NEMA that can assist you with EMAC movement of public health and medical personnel. But we really feel that mutual aid planning, it's really important to build capacity and deploy and operate self-sufficiently our volunteers. It's all voluntary. We want to build on what already exists. We want to keep it simple, consistent. A lot of these things are things that we're all aware of with mutual aid planning, but they're very important to kind of think about as we're doing that local and regional and state planning. Engaging your volunteers, I think, is a really big thing, and it's something that we've been really working on for many years on the medical side with the ESAR-VHP at the federal level, the electronic system for the advanced registration of volunteer healthcare personnel, and the state-based volunteer registries that we're developing. And I think now public health, although they haven't in the past been engaged in this national system and some of the state-based systems, this is a perfect time for these job titles to become parts of these systems if they're not already. So these are a good starting point for public health and medical volunteers. Use these registries, get your public health and medical people credentialed and to meet the requirements in the system, and you're pretty far ahead in getting things ready for deploying these volunteers. As far as mutual aid planning, just to finish up, I'd like to say that it's very important that when you do request medical or public health assets that you really specify the clinical area and the mission assignment that you want the medical people for. Really the length of deployment, an accurate mission assignment. It's very important to ensure that the staff that are requested or that you send are qualified to care for the people that you want cared for. The individuals responding in teams really do have to have the clinical knowledge and skills, and I think we were very careful in the credentialing in stating that we really wanted people that had certain types of experience, minimum level of experience in established healthcare settings, that really were commensurate with the type of mission or assignment they were going to have. And as a general rule, the states needed to really determine the number of teams based on the patient care needs. Most of our teams were based on 25 patients per team per 12-hour shift, especially on the medical side. And so we really asked the requesting states to say, to really think about, how many, maybe I need 2 or 3 of these teams. One may not be enough because one really covers just a 12-hour shift. So where do all of we as ESF8, public health and medical professionals fit in? We got to find out what our plan is, and you don't know that unless you talk to your local emergency management director or your regional one or at the state level. Make sure that if you have identified yourself as an interstate responder or want to be someone, look at what those requirements are and make sure that you meet the training requirements, the education requirements, and really work within your states and jurisdictions to help your agency understand what this process is. What is resource typing and credentialing? How can I fit in? We've started that process in Connecticut with our local health people years ago now, and have really come a long way based on the resource typing and credentialing documents that have come out. They're all working at the local level to find out what teams they would be part of, what job description, what job title they would meet, so they have all this pre-planning and documentation ready before an event actually occurs. Keep things simple, like I said before. Focus on large-scale mutual aid, build on lessons learned, and I think what I had said before, pre-planning is really important. Do as much work proactively in advance to relieve the burden on yourself if you have to receive help or if you want to respond to someone that's requesting help. And lastly, I think realize the limitations of infrastructure and support services that may be there at the receiving location, and all those things are incorporated into the tools that we've been developing for you. So now I'm going to turn the mic back over to Leon so we can move on to the next segment of our presentation.
Great. Thank you, Mary, for sharing your views on these very important matters. You've identified a number of public health and medical issues, I think, that are facing the profession that the profession probably needs to look at and address in the near future in order to meet these medical surgery requirements, some of these emergency conditions that you described. Your views on typing and credentialing, especially interstate and interstate mutual aid planning, is a perfect segue for our next session. And our next session will be presented by Kathy Robinson. Kathy is a project advisor and subject matter expert for the National Resource Typing and Credentialing effort. She is an experienced critical care and emergency nurse with a background in healthcare administration. She has recently served as the clinical program manager for the Bureau of Emergency Medical Services at the Pennsylvania Department of Health. She is a current program manager for the National Association of State EMS Officials located in Falls Church, Virginia. Kathy is also a registered nurse and a paramedic. Kathy will explain during her session how developing resource capabilities into mission-ready packaging before a disaster occurs can greatly facilitate the identification, the availability, the ordering, and deploying and utilizing public health and medical resources through the EMAC system. Kathy?
Thank you very much, Leon. I'd like to echo Mary's sentiments to the group that has called in today. We're pleased to have you join us for this important session. I think that Hurricane Katrina did a lot of things in enlightening all of us about the need to plan for those kinds of events in our own neighborhood. included a picture of mission control at NASA here on the slide, just to make the point that the government doesn't decide to send a space shuttle or a rocket up in a day's time, or when there is a special event. That many months, many years of planning really go into providing a successful mission. And Mary previously suggested to you, and a component that I would like to emphasize is that states need to perform a needs assessment to identify their existing resource shortfalls and to pre-coordinate requests for assets. That pre-planning and identification of assets that can be made available to the affected states. And I think that we're all learning more about this area of resource management and requesting assistance and how to receive assistance. I think back about the time that 9/11 occurred, which we learned a different set of lessons from, where many people felt compelled to load up personal gear and travel to New York City to provide assistance. And what we've learned through that and many other events at time is that having individual responders really complicates matters for the jurisdiction that is receiving assistance, because now they have to figure out how to house and manage an influx of personnel that they didn't anticipate. Mary talked a little bit about the ESF-8 resource typing initiative that we've been working on for the last several years, and I think what we're realizing is that there are always lessons to be learned. In spite of a comprehensive set of planning efforts, that the details change, the personnel change, that there's just a lot of things that we can't plan accurately for. So our effort with resource typing was really intended to build on state and local resource typing efforts. Many of you already have some descriptions available. We're not suggesting that you need to change those or replace those. But what we learned was a lot of states did not have those sorts of descriptions available to them. And when hospitals or other sorts of medical units felt that they had resources that they were able to share, there really wasn't a good way to do that, because they hadn't been identified, they hadn't been credentialed, they really hadn't been counted as part of a disaster response unit. So we're here to tell you, and those of you that have had experience in these sorts of events, is that the actual mission requirements always vary from the plans. That as much as we try to write accurate descriptions around these sorts of things, we still need to remain flexible and in communication with each other to make sure that what is being requested is what you're capable of sending. So rather than having you focus on the individual teams or the individual resources that have been typed, we want you to think a little bit more about the mission and what is really needed. The saying here that you may have heard in other venues, if you've seen one bomb, then you've seen one bomb. The point of that being that there are many variabilities, that things change. You know, just the format of deployment sometimes changes, that you can't take a single incident and expect that you've had full experience in the range of activities that may be needed. So requirements will vary, and so should the capabilities. And the resource typing teams are really written in a broad sense with an intent to be flexible, but by focusing on the mission, you can greater assure that if you require a team to work in an emergency department, for example, that you aren't receiving personnel that's qualified in obstetrics or some other type of specialty. Federal and state response teams have and will experience unique differences in their mission requirements, operational realities, and the ability to staff, recruit, and sustain them. As monies come in and out of the disaster preparedness realm, the ability for local jurisdictions to maintain readiness is affected. So we are encouraging states and local jurisdictions to avoid building team structures that never deploy, and to remind folks that readiness depends on regular training and experience in deployment. You may be familiar with the disaster response mission packages that have been posted on NEMA's website for several years. Actually, the screenshot that you see there is the most recent ones. We've been working within the Medical Public Health Working Group to provide some descriptions really around the teams and personnel that have been identified. So with regards to mission-ready packages, our proposal in regards to medical support really is about hospital augmentation packages. We have not spent a lot of time talking about equipment caches, the sorts of supplies that people need to take with them, and we encourage you to maintain inventory lists, or if you think that you're in an area that may need to receive folks, the types of equipment that you may request in the case of a disaster. We also developed some descriptions around public health assets, and none of these really required intimate knowledge of ESF-8 resource type teams to request assistance. So as Mary described, those specific teams, again, all of our message really is to focus on the mission and what it is that you need to accomplish with what you're facing. So in regards to the medical hospital augmentation packages, we've really talked about a range of capabilities. You can't expect specialists from one area really to be interchangeable with another area, so we've identified a description around emergency and critical care, adult patient care services, acute surgical and trauma services, high-risk prenatal and OB, laboratory, a mission support function that can really kind of be there to support a medical team that is on site, acquire additional equipment, acquire additional support, or what might ever be needed in that regard, mobile field medical services, pharmacy services, and radiology services. And we recognize that there are probably many more that we should describe. The working group really is in the early stages of planning and writing in this regard. So we're always open to suggestions for areas that you think need to be defined. As Mary indicated, we are developing some descriptions about around fatality management. We recognize that there are many, many other services that may require support during a disaster. The public health packages really were quite simple. Those descriptions include epidemiology, surveillance, and investigation functions, isolation and quarantine, environmental health, mass dispensing consultant, and receiving, staging, and storing task forces. And really the intent is to augment the staff that is already on site, to supplement the services that they're able to provide, and make sure that that victims and others really get what they need. As an example, the mission-ready packages that we've described around the emergency critical care services, I'm going to extract a couple areas from the data collection tool with regards to emergency and critical care services, just to illustrate what types of things that we're talking about. So this particular discipline, for example, would be able to provide care in a defined emergency and critical care area provided in an existing hospital facility. This really wasn't written to describe functions that are outside of a hospital. And if a hospital has been decimated and really isn't able to function as a hospital, this really wasn't intended for that sort of support. The description of the resource would be specialized and discipline-oriented care to acute patients in an emergency department or ICU setting. The requesting jurisdiction, as Mary indicated, must specify what type of support that you need and what the location would be in order to receive the kinds of specialists that would be capable of functioning in those areas. For example, you could specify adult, or you could specify pediatric, or you could specify that it's an emergency department that is capable of treating both adult and pediatric patients. Likewise, you would need to include in your request for assistance whether the location is an emergency department or an alternate care facility, such as something that might take place, unfortunately didn't take place during the recent pandemic, but that we've all discussed for providing support to hospitals, or whether that might occur in a critical care area. The missions that's supported is, again, hospital staffing, because that seems to be the greatest need for these types of personnel. Certainly there are mobile hospital units and field services that are capable of providing medical care in a field setting. Again, this is a description around care that would be provided in an existing hospital facility. Some of the limiting factors, and Mary alluded to some of those, is that we've really talked about providing staffing only. This particular mission-ready package is not written to include hazmat situations. The timing may be affected because of the distance from the home station to the disaster area and transportation capabilities into an affected area. Keep in mind that many of these folks actually are moving away from functional hospitals and healthcare facilities, so the time that they may have to provide mission support can be limited. If you are seeking assistance, the length of time should be indicated on the request so that information can be communicated. There are some hospitals that would be able to provide support for a longer period of time, and some cannot. If you don't take anything else away from my from my section here, the importance of communication really is paramount, and making sure that you clearly articulate both what is needed and what you're capable of providing. That we don't expect these folks to function in 24-hour shifts, that really they're going to need to have some downtime, so that if Mary also mentioned that you need to take into consideration the number of patients you're dealing with and the number of shifts in order to request the proper amount of resources. So what might an emergency critical care package look like? We're talking about having personnel that includes a medical unit team leader, at least one physician. We encourage the use of physician's assistants and advanced practice nurses, 13 registered nurses, a respiratory therapist, a radiology technician, a pharmacist, and patient care technicians or certified nursing assistants. And again, many of the descriptions around these types of resources are included in the resource typing information that is available on the FEMA website. And you'll hear us say this many, many times during this webinar, that it is a critical issue that sufficient detail be provided to ensure that the assisting state will provide the appropriate resources to meet the specific need. And we recognize that this particular slide doesn't represent a domestic scenario, but if you've been on the receiving end of equipment and supplies by a lot of well-meaning folks, you can appreciate the fact that we need to communicate clearly about what is needed in this particular regard. And with that, Leon, I'll throw it back to you, and look forward to receiving any questions at the end of the presentation.
Well, thank you, Kathy. Your input today was certainly a practitioner's endorsement of pre-planning and packaging resources in order to become more efficient in deploying public health and medical assets to assist other affected states, especially through the EMAC system. Very experiential presentation there. Our final session today will be presented by Dr. Martha Salyers. Martha is a member and team leader of the Public Health Regional Surveillance Team number 6 out of Asheville, North Carolina. This is one of 7 regional teams that serve 16 health districts, the Eastern Band of Cherokee Indians, and a network of stakeholders in public health preparedness, consultation, technical expertise, planning, training, and response in the state of North Carolina. Martha also serves on FEMA's NIMS working groups and is a co-chair of the NIMS Public Health and Medical Working Group along with Mary Duley. She received her medical degree from Michigan State University and her master's degree in public health from the University of North Carolina in Chapel Hill. And has worked in local and regional health departments areas for over 13 years. Martha will now share her personal experience from a resource provider's point of view, using the EMAC system to provide public health and medical resources from the state of North Carolina to the state of Mississippi during Hurricane Katrina. Martha?
Thank you very much, Leon, and good afternoon, everybody. My objectives for this afternoon, or for this portion of the presentation, are only a couple, and really what I'm trying to do is to tell you a story about a Katrina deployment that knits together and underscores what Mary and Kathy talked about, as well as the powerful work that NEMA and EMAC have done over the past several years. So I'm going to talk about North Carolina's Mobile Hospital Emergency Management Assistance Compact, or EMAC, response in southern Mississippi post-Katrina, and try to talk about those experiences in relationship to EMAC and resource typing. How we got there, I think everybody remembers very well. It wasn't that long ago what happened during and after Katrina. But just for a quick memory jog, on August 23rd of 2005, Katrina made landfall in southern Florida as a Category 1 hurricane. 6 days later, it made its second landfall in southern Mississippi as a Category 3, and got as far inland as 150 miles in Jackson. Wind speeds were very high, up to 175 miles an hour, and storm surges got up to 37 feet. Katrina, as you'll recall, caused about $115 billion in damage overall, and in Mississippi caused 238 deaths. Infrastructure in southern Mississippi, needless to say, was completely devastated. And during the week of August the 29th, Mississippi requested from North Carolina ESF-8, that is medical and public health assets, to meet the needs of about 7,000 residents of the Waveland, Bay St. Louis area. The hospital there had been made completely inoperable, and local resources, including utilities, were completely wiped out. Just for quick reorientation, here's the location of the Waveland, Bay St. Louis area. And here's a bit of a closer view showing that Waveland and Bay St. Louis are between Gulfport and, in the bottom left-hand corner, New Orleans. This is a helicopter view of the Waveland area, and this is what was seen by our deployees when they got there. The area was completely decimated. This is the only picture I'll show of this damage, because you've seen plenty of them, but our deployees described this as like a war zone and like a nuclear bomb had been detonated. Note that even the leaves had been stripped from the trees. Waveland, I'll refer to it as Waveland as we go on, is in Hancock County, and this is the Hancock County Medical Center, the hospital which is the only one in the area, and again was completely out of service from storm damage. It may not look too awful on the outside, but this is pretty much what it looked like in patient care areas on the inside. So after Mississippi requested ESF-8 assistance from North Carolina, members of North Carolina's state medical assistance teams and the Carolinas Healthcare Center, Med-1 mobile hospital, were deployed. They went in a caravan, as you can see here, and stopped en route to stage at Camp Shelby, Mississippi, where they waited until their deployment destination was clarified. They initially thought they were going to New Orleans, but en route their destination was changed. Just a real quick word about the tiered system in North Carolina. Our State Medical Assistance Team 1 is our Disaster Medical Assistance Team, or DMAT. Our SMAT 2s, which you see here in the caravan, include mobile alternate care facilities and staff, as well as material and supplies. Our SMAT 3s are local teams distributed around the state with primarily decontamination and surge capacity capabilities. So when they got to Waveland, this is what they saw. This is a Kmart parking lot where they were destined to set up. It was covered with debris and abandoned vehicles. There were dead bodies in and on the building and alligators inside. But with the help of a flat-bottom boat fan and bulldozers courtesy of the National Guard, The lot was cleared, and the abandoned vehicles were used to help create a perimeter. The team also took some red spray paint and found that if you put a big red H on the ground, helicopters would start landing there. So they did have a helipad that they used for medevac and supplies. In addition to the abandoned vehicles, the perimeter, the staff used impromptu fencing, and security was through the SWAT team from Mecklenburg County, which is where Charlotte is in North Carolina. This is a photo of the beginning of the setup of Carolina's Med 1. What Med 1 is 2 53-foot trailers. This capability was conceived in 2000 as a mass casualty transport vehicle, but was developed as an on-scene treatment facility with Department of Homeland Security Metropolitan Medical Response System, MRS, funding, and led by Dr. Tom Blackwell out of Carolina. It includes surgical, critical, and emergency care units and equipment. There's X-ray, ultrasound, lab, 72-hour medication cache, communications, power, and patient care staff. The patient care trailer is surrounded by this tent, which enables 200-plus outside beds for ambulatory or inpatient care. And this is an aerial photograph of the Kmart parking lot with the entire facility set up, including supply and communication trailers, staff housing, the incident command post, and the triage unit. The triage unit, which is the blue tent that you see in the foreground, was actually a repurposed decontamination unit from the North Carolina ESMAP 3. As you can see, signage was basic along with everything else. You'll note that there is an indicator to the right saying FEMA, and that's because FEMA and the American Red Cross co-located their services in the parking lot for a one-stop shopping. This is a photo of the interior of the triage tent. It was very busy, and it was open 24 hours a day. This is a shot of the ambulatory or inpatient unit. It was used for both. And as you can see from the fans, they needed them. It was in the 80s to 90s during the day, and I was told by many people that it was 100+% humidity at all times. On the left, you can see the shell of the interior hospital units, and this is an interior shot of Med 1 with their inpatient capacity, surgical capacity, and ICU or critical care capacity, as well as lab and pharmacy. In addition to having the hospital set up in the parking lot, logistics was a real challenge because there were really not very many facilities to do logistics in. As you can see, some of it was done outside, and electricity was completely portable. Staff housing was also very basic. People slept in cots under awnings, they slept in tents, or even as in this photograph, in pod boxes. You can see from the mosquito netting that vector control after a few weeks became a problem. Also, this reminds me to comment on what Kathy brought up about work-rest shifts, assuring that people have 12-hour work-rest shifts, because during this deployment that was a big problem, people not observing the division between work and rest, and overworking, getting either dehydrated or overtired. Over about an 8-week deployment in Waveland, over 500 North Carolina personnel in the SMATs and Med 1 and associated agencies, volunteers, and more, cared for about 7,500 patients in this mobile hospital. Everything from minor urgent care to life-threatening illnesses, even requiring intubation, and including even a beloved dog who turned out to have a pelvic fracture. Through it all, there was no significant foodborne outbreak or nosocomial outbreak. Now, I'm going to move on and talk a little bit about public health roles, since that's my background in this response. I want to start with a disclaimer, however, because I did not deploy during Katrina with North Carolina resources, but I'm here to brag about them. I was part of the home team back in North Carolina, which we actually needed because Hurricane Ophelia happened to come and hit us a couple weeks after Katrina hit the coast, the Gulf Coast. So, public health roles. Initially, public health tasks weren't part of the deployment process, but in short order, a need for epidemiologic surveillance was identified, both for staff who had begun to have some symptoms of rashes and slight GI illness, and for tracking patients as they came in and reporting them their conditions and their diagnoses to state public health. Epidemiologists, whom you see here, the two folks on the right, created a database to track selected variables using the Mississippi Department of Health and CDC surveillance forms. Epidemiological support actually became embedded in hospital operations very quickly, and in addition to doing public health surveillance, they created daily reports for briefings. They helped set up patient records and contributed to staffing level decisions in the mobile hospital. Environmental health was also a very important component of the response. Environmental health strike teams helped to inspect and monitor staff feeding operations, one of which you see right here. And they also did courtesy inspections and helped monitor public feeding operations. Public feeding operations were done completely on a volunteer basis by a local church with a lot of additional help from Interstate, faith organizations, and even the American Rainbow Rapid Response. One big issue that environmental health was very strategic in was biomedical waste. When the first environmental health deployees arrived, they found that that biomedical waste and regular waste were being mixed up in the dumpsters and in piles all over the refuse area. So they had to go through and figure out a policy and procedure for dealing with biomedical waste and assure that they were appropriately separated and appropriately packaged. Also, environmental health as a strike team inspected on-site water sources. There was a non-FDA approved water purification method in use for hospital water supplies. Bottled water was used for drinking water. The local water supply from a hydrant was tested downstream from the purification apparatus and was found positive for fecal coliforms. So environmental health implemented safer water purification and continued monitoring. The lessons learned from the North Carolina deployment to Katrina, which was a powerful experience for everyone who participated, were many, and I'll try to summarize just a few of them as they apply to our discussion today. First, North Carolina resources were organized, equipped, and exercised for deployments. However, this was the first time that these two systems had deployed together, Med1 and the SMAPs. But even though it was their first time, they were able to figure out how to do that with success and to integrate with the local EOC, Mississippi Department of Health, CDC, and other partners to give service in an austere environment. Another major lesson learned was that EMAC, even then, was the national standard for interstate deployment and has become even more so. Some of the things we learned about using EMAC in this deployment were that, one, there's no self-deployment for interstate assets. That was true then, it's true now. Even from North Carolina, we had some folks who went down solo. It's been made clear that that does not happen, that everyone has to be registered through EMAC and deployed through EMAC. What Kathy was saying about well-defined and mutually agreed on missions is extremely important. When things are moving fast and there are powerful needs, it's even more important for missions to be clear and requests to be clear. Staging must be done up front with clear logistical communications and management support. And you've heard document before. This is especially important with EMAC deployments. Specifically with public health roles, we need to continue to develop them. Both Mary and Kathy talked about public health and medical resources that have been typed and credentialed and to some extent mission packaged. So we need to build on those teams, credentials, and mission packages, develop the mission packages for every type of resource, and make sure that we include basic public health functions in mobile hospitals, and that mobile hospitals deal with these issues and others in their function for the best service. One major lesson was that behavioral health resources are extremely important for demobilized staff, both on-site and after they return home, and that's something that North Carolina is working on right now. Of course, we must integrate all of ESF-8 resources. We can't do any siloing of public health and medical within ESF-8. We're all in it together, and as you see from some of the team typing that we have done, this has been recognized. In closing, real quick, I want to acknowledge all the folks I talked to who are my colleagues who deployed, and the work of all the North Carolina Katrina responders, from agencies to the Carolinas Healthcare down to our locals. And last, I want to thank, from the bottom of my heart, all of our North Carolina responders, the Mississippi responders, and all the brave residents of Mississippi. This is a reminder that even if the buildings are gone, the spirit of the community remains. This is the conclusion of my part of the presentation. I'm going to turn it back over to Leon.
Thank you, Martha, for what I considered personally to be a very passionate presentation. You'll all excuse me if I digress just for a second. As a lifelong resident of Mississippi and a past emergency management official, I personally want to thank you, Martha, and the state of North Carolina for the assistance you provided our state during that very perilous time. I also want to thank all of our presenters today for sharing their personal experiences and their knowledge with their peers in the public health and medical profession, and extending their knowledge base with this important information. I hope these two public health and medical seminars that have been presented have met all of your expectations, and that you gained a lot more information from listening to these practitioners and experts in the field that have been presenting today. Now let's go back to Angela Koppel, who will field any questions that the audience may have posed. Angela?
Has the NIMS typing system identified mental health teams for critical incident stress?
Actually, we've had a discussion about that. We've had folks from SAMHSA and other mental health professionals involved with the working group, and they have not been typed specifically yet. Actually, Mary and Martha might have some thoughts about that. Like I said, we started out with a very basic of resources and trying to get some descriptions around those, and actually intend to expand that into other specialties.
This is Mary. I will add that out of the 44 public health and medical job titles, there are at least 7 or 8 of them that are licensed and unlicensed behavioral health professionals, and all of the teams, specifically the mobile field medical teams and some of the specialty teams, have behavioral health personnel embedded in them. We have, however, been recently asked to reconsider looking at developing separate, unique behavioral health teams on their own, and already having the personnel credentialed. That will probably be a relatively easy thing to do, and was going to be something we would be investigating after we finish the fatality management teams.
Okay, great. Next question is, are equipment repair specialists such as biomedical technicians normally part of a deployment team, or are they available on site once deployed?
I can take that, Angela. This is Kathy. We actually, Mary mentioned early in the presentation that we're looking at, we're currently working on it. I don't want to use the word logistics support, but I guess I'm going to have to, because in the meantime I don't have a better one. But technicians and other individuals that would be critical to supporting a medical team on site. So they may include a biomedical technician of sorts. It would also include medical records personnel, communications personnel, safety personnel, and that's one of the teams that you'll be seeing coming out in the near future.
Okay, great.
Angela, can I add something? This is Leon.
Absolutely.
This would be a good opportunity to bring out the real value, again, as Kathy talked about mission-ready packages in her presentation. Having an opportunity to look at components of a particular resource asset that's being packaged. If there's a limitation or a shortfall in a particular package that might be identified as a need that some other provider can offer up. For example, if a logistics package or component is needed, but it's not a part of a particular package that's being developed or that has been developed, then that could be identified in the request and offer phase, identifying that need for some other provider to provide that particular asset to support that team's mission.
Our next question is, concerning the logistical support packages that are on site during a deployment, such as, is law enforcement part of the mobile package that needs to be deployed with, say, a mobile pharmacy, or is that something that arrives on site from another source? Who actually brings those resources in?
Well, I kind of think that, if I may, that answer, the answer that I gave a moment ago could probably apply to that as well. We've had discussions with law enforcement professions in the past about providing security for pharmaceutical packages or push packages and things of this type, as well as other security measures. And those issues would be identified usually by the requesting state as an additional resource requirement or an additional logistics requirement that might be needed to be brought in to support a package if that law enforcement or security piece is not a part of that original request.
And Leon raises a very important point. We're talking about a specific discipline today with regards to public health and medical. There are several other working groups that are providing resource typing efforts around other disciplines, including law enforcement. There's some other ones, animal health, emergency medical services, search and rescue. If you go to the FEMA website that Mary pointed to in her presentation, you'll see the work of the other working groups available on that page as well.
Okay, great. Thank you. Well, we have reached the end of our hour. I want to thank all of our presenters today and Leon for facilitating our session. And I want to thank everyone else for joining us today.